Welcome to the DjamgaMind USA series. I'm your host, Etienne Newman. Today we are decoding the CMS Interoperability and Prior Authorization Final Rule, better known as CMS-0057-F. This is an 847-page mandate that fundamentally changes how fast you must move. If you are a payer or provider, the days of unlimited review time are over. You are now on a 72-hour clock for expedited requests, and you must report your denial rates publicly. Our AI intelligence agents have analyzed the full text to debate the hidden risks, the API technical requirements, and the compliance deadlines you might miss. Let's enter the simulation.
Welcome to the deep dive, where we take these massive policy documents, these huge regulatory proposals, and we turn them into something you can actually use.
Exactly.
And today, we are tackling what is, truly a monumental shift in U.S. healthcare. This is a huge infrastructure upgrade, really, and it's all being driven by federal mandates around data and prior authorization.
Yeah, this is the big one.
The source material we're digging into is the CMS-0057-F final rule. And you know it's a big deal when a policy doc gets nearly 900 comments from everyone in the industry.
Right. That's not just fine print. That's a signal that every single major player, from the big insurers down to small provider groups, knows this is going to fundamentally change how they work.
So what's our mission today?
I think our mission is to unpack how CMS is essentially dragging health administration out of the fax machine era. We're looking at how these rules hit four big targets at once: boosting data exchange, streamlining that awful prior authorization process, cutting down on provider burnout, and, at the end of the day, helping patients get care on time.
Okay, so who's on the hook for this? Who are the impacted payers that have to build all this new tech?
It's a huge slice of the market. We're talking Medicare Advantage organizations, state Medicaid and CHIP programs, both fee-for-service and managed care.
Okay.
And also qualified health plan issuers on the federal exchanges, the FFEs. Basically, if you're involved with federal programs or marketplaces, you're building these systems.
Got it.
But before we get into the technical guts of it, there's one really critical thing to flag right up front for you.
What's that?
These new prior authorization rules, they do not apply to drugs at all.
So wait, no prescription drugs,
Yeah.
nothing a doctor administers in a clinic.
Correct. Zero drugs. It's an intentional carve-out. Drug authorizations, especially with PBMs, they operate under a totally different kind of mature set of rules and tech standards.
Okay.
Yeah, trying to force them into this framework would have been a mess. So for today, just think medical services, procedures, and equipment.
Okay, that makes sense. So let's unpack this. The core of the whole thing, the real engine, is this mandate for three specific application programming interfaces, APIs.
Right. And for anyone not super technical, just think of APIs as standardized digital pipes. They're what let all these different computer systems that never used to talk to each other finally connect securely and, instantly.
And it's the standardization that's key. CMS isn't just saying build a pipe.
Exactly. They're saying everyone has to use the same material, the same fittings. Specifically, it's all built on Health Level 7 Fast Healthcare for Interoperability Resources.
FHIR. We hear that acronym all the time.
FHIR, yeah. Specifically, Release 4.0.1. Think of FHIR as the common language. It forces not just the connection, but the structure of the data to be the same everywhere. It's the only way this could possibly work by the 2027 deadline.
Let's start with that first pipe then. The Provider Access API. This one seems aimed at a huge point of frustration.
Oh, it's the biggest. A provider today might only see the data they created, while the payer has the patient's entire history. It's a totally fragmented and, frankly, dangerous way to work.
So this API fixes that.
It's designed to. It requires the payer to send a whole bundle of data to an in-network provider when they ask for it. We're talking claims, clinical data using the USCDI standard, and this is critical info on prior authorization statuses.
And the benefit there is pretty obvious.
It's huge. Your specialist can suddenly see labs your primary care doc ordered last week. It cuts down on duplicate tests, saves a ton of time chasing records.
And what really gives it teeth is the speed, right? There's a time limit.
Yes. Payers have to make the data available no later than 1 business day after getting a request.
1 business day.
That's a game changer. It moves the data from being a historical artifact you wait a week for to something you can actually use in the clinical workflow right now.
And the scope is limited just to in-network providers.
For now, yes. It's for security and privacy. They have to have an established treatment relationship to get access.
Okay, so that's the data flowing to the provider. The next one, the peer-to-peer API, seems to be all about the patient's journey.
It is. It's for when you switch insurance plans or for people with concurrent coverage.
Like dual eligibles.
Exactly. That's the perfect example. The rule says payers have to exchange patient data with previous or current payers. And for concurrent coverage, they have to sync up at least quarterly.
But the patient has to agree to this first.
Absolutely. It's strictly opt-in. The new payer has to ask you for permission within a week of your coverage starting. It puts you in the driver's seat.
Now, here's where I thought it got really interesting. The rule says that denied prior authorization requests are excluded from this payer-to-payer exchange. Why would they do that?
It's a fascinating and, I think, very thoughtful policy choice.
It seems like you'd want the full record.
You'd think so, but CMS was worried about creating a kind of institutional bias. They feared a new insurance company might see that a service was denied by a previous one and be, predisposed to deny it again. A denial is a coverage decision, not a clinical fact. By excluding it, they're making sure every patient gets a clean slate with their new plan. It's a powerful little detail.
That is powerful. Okay, so we've got data to the provider, data between payers. The last API tackles the biggest headache of all, prior authorization.
The administrative monster. Yeah, this API is meant to be the automation engine for the whole process. It lets a provider's own system, their EHR, first check if a PA is even needed for something.
So no more logging into a dozen different payer portals.
That's the goal. The provider's EHR can query the payer system, see the requirements, and if a PA is needed, it can automatically package up the clinical notes and submit it. The payer has to publish a machine-readable list of everything that needs a PA.
And the API handles the whole conversation, back and forth.
The whole thing. A HIPAA-compliant request and response. It'll communicate back if it's approved, denied with a specific reason, or if they just need more info. And again, this whole thing has to be up and running by January 1st, 2027.
Okay, so that's the big tech build-out for 2027. But you mentioned some things are happening sooner, in 2026. Things that hit provider burnout right now.
That's right. They're not making providers wait 3 years for relief. A couple of major process changes kick in on January 1st, 2026.
And these are mainly about speed and transparency.
Exactly. For a standard, non-urgent prior authorization request, the decision timeframe for most of these payers gets cut down to just 7 calendar days.
7. Down from what?
Well, in some cases, it was 14 days, or even longer depending on the state or plan. So cutting that in half or more is a massive acceleration.
And what about for urgent requests?
For expedited requests, the timeline is now set at a maximum of 72 hours across the board. This stops those dangerous delays in care and frees up staff who used to just be chasing down paperwork.
For me, the most powerful change in this whole section is about the denials. The rule says payers have to give a specific reason for the denial.
Yes, that one is huge for clinical workflow.
It seems so simple, but what does that actually change for a doctor's office?
It changes everything. Before, you might get a denial that just says, not medically necessary, or cites some internal policy number. It was useless.
And you have to get on the phone for hours.
Hours! Now, the denial has to say something specific, like imaging criteria Y was not met. The provider immediately knows what to do next, appeal with more info, try a different approach. It cuts out so much wasted time.
That transparency push continues with public reporting, too.
It does. Starting in 2026, payers have to publicly post a whole bunch of metrics about their PA process every year.
What kind of metrics?
A full list of everything that requires a PA, for starters. Then, the percentages of requests that were approved, denied, or approved after an appeal. And my favorite, the average and median time it took them to make a decision.
So you can actually compare plans based on how efficient they are.
That's the idea. It creates market pressure. No insurer wants to be the one publishing a 20-day median wait time when their competitor is at 5. It should drive real performance improvement.
So let's talk about the standards behind all this. For you listening, knowing what's set in stone versus what's flexible is key to understanding this rollout.
Right. So we know the core is mandatory. FHIR 4.0.1 and the US CDI data standard. That consistency is non-negotiable for all 3 of the new APIs.
But I remember reading that not every single technical guide is being mandated yet.
Correct. And that's a smart, pragmatic move by CMS. They're strongly recommending certain implementation guides, IGs, like the ones for discovering PA requirements or submitting them, but they aren't locking them in as a hard requirement.
Why not?
It acknowledges that some of these standards are still evolving. This way, the industry can refine best practices in the real world before they get cemented into federal regulation. It allows for a bit of breathing room.
And that flexibility extends to security, which seems a little surprising.
It does, but it's based on the use case. For the patient access API, where it's you logging in to see your own data, that requires a specific, very common user login protocol.
Okay.
But for the big, automated system-to-system APIs, the provider access and payer-to-payer ones, they're not mandating that. They're recommending other standards that are better built for high-volume back-end exchanges where a person isn't typing a password each time.
And the timeline itself, pushing the API deadline from 2026 to 2027, that was a big concession.
Oh, it was a necessary one. The industry feedback was overwhelming. They made it clear that building this complex new digital infrastructure was a monumental task, and they just needed more time to design, build, and test it properly.
It shows they're listening, at least on some things.
I think so. And they also built in some off-ramps. States with really small Medicaid populations, for example, can apply for an exemption, but, and this is a big but, they have to prove they have some other efficient electronic way for patients and providers to get the data. They can't just go back to the fax machine.
So when you take a step back, this deep dive really shows a massive coordinated push to modernize healthcare data. It's moving the whole industry toward a structure that, we just take for granted in banking or e-commerce.
Absolutely. Secure, transparent, and portable. That's the goal. And it hits all the right notes. It gives patients more control, it gives providers better tools and faster answers, and it gives payers a way to ensure continuity of care. It's an infrastructure revolution, really.
And that brings us to our final provocative thought for you to take away from this.
Yeah.
CMS has mandated that payers build these incredibly robust, standardized digital pipes by 2027. So the infrastructure on the insurance side will exist.
Right, the pipes will lay there.
But the ultimate success of these new APIs, especially in reducing that provider burnout we talked about, it all depends on whether providers and their electronic health record, their EHR vendors, actually adopt and use them.
And that's the catch. This rule doesn't mandate anything for providers or EHR companies. It only mandates that payers have to offer these tools. So it raises this huge question. Is the simple availability of a better digital pipe going to be a strong enough market force to make EHR vendors build the integrations? Or will we end up with billions spent on brand new infrastructure that nobody fully connects to, leaving us with the same fragmented system we have today?
That was the intelligence briefing on CMS-0057-F. The key takeaway? This rule isn't just IT compliance, it is reputation management. With the new public reporting requirements, your denial rates will be visible to everyone. If your APIs aren't ready by the 2026/2027 deadlines, you risk falling behind. To get these briefings delivered to your inbox every Monday morning, subscribe to the full USA series at DjamgaMind.com. Don't read the regulation. Listen to the risk. I'll see you in the next briefing.